The communication station component of the Part 2B Clinical Oncology FRCR examination is 10 minutes in duration. Candidates are allocated an additional 2 minutes prior to the role-play encounter to read the candidate briefing. The station is based around an interaction with a role player, with the scenario and candidate instructions detailed in the candidate brief. The station assesses 3 key domains: general communication skills, managing concerns in a clear, professional and empathetic way, and effectively communicating medical issues and explaining a management plan. The following videos have been developed to aid in the preparation for this component of the exam. Please note this is a simulated role play and highlights areas of effective practice and less effective practice. The second video does not represent the clinician's normal approach. For this communication skills scenario, the aim is to explain adjuvant chemotherapy. I will now read out the guidance to the candidate that would be given to you to read prior to meeting the role player. The patient recently presented with anemia and a diagnosis of cecal cancer was made at colonoscopy. They've undergone a right hemicolectomy for a T3, PM1, M0 cecal adenocarcinoma. They work as a writer, have no significant comorbidities, and are WHO performance status 0. They made a good recovery post-operatively and met their oncologist recently to discuss adjuvant chemotherapy. It was recommended that they have 3 months of adjuvant oxaliplatin and capecitabine chemotherapy. The side effects and potential benefits were explained, and the patient signed a consent form. The clinic letter mentions that the oncologist told the patient that chemotherapy in this setting would improve disease-free survival at 3 years from 75% to 90% and improve their 5-year overall survival from 55% to 70%. Today, they have come to the chemotherapy unit to have their first cycle, and the nurse has contacted you. The nurse is concerned that the patient does not really seem to understand what the treatment is for and has some other questions. The nurse would prefer not to start chemotherapy until a doctor has spoken to the patient. You will then have 10 minutes to interact with the role player, where the 3 domains discussed earlier will be assessed.
Your reading time is now finished and your 10 minutes is starting. Please start the consultation.
Good morning. My name's Jill Bishop. I'm one of the doctors on the unit. Can I just check your name?
Yes, I'm Angela Brown.
Okay. What do you like to be called?
Angela is fine. You can just
Angela
use my first name.
Okay, that's fine. So can I know what my nursing colleagues have told me, but can I just check why you wanted to have a chat?
Well, I had a conversation with the nurse just a little while ago, and she seemed a bit concerned and thought that I should speak to a doctor because of just some things that I was saying to her. She basically thought that I had, like, as if I didn't actually understand what the chemotherapy was for. She felt that I had kind of unrealistic expectations. I was just saying to her that, I'm really sure that the cancer won't reoccur. And she said that that's not necessarily going to be the case with treatment.
Okay. So would it help if we talk through some of your worries and your thoughts? Would that help? Okay.
Yeah, please.
Okay. If I've understood correctly from your notes, you had a cancer of your gut and you had an operation for that, and the operation went well.
Yeah.
And you're recovering.
Yeah, recovering. I've still got my scar is still very sore, but I am now just beginning to be able to walk and just starting to think about doing a bit of work.
Okay, that's great. And you saw one of the consultants and they talked to you about using some chemotherapy.
Yeah, I had a long discussion about chemotherapy. The oncologist thought that I should do 3 months worth of it. He seemed very knowledgeable and very confident about it. I was quite impressed by his suggestion.
Okay.
Yeah.
And can I check because of what you said about the nurse's concerns and your concerns. Can I check, what did you understand about the chemotherapy?
Well, I left the meeting with the understanding that the chemotherapy would stop the cancer from coming back, and that also it would mop up any cancer cells that are still left in my body.
Okay.
And that's why I signed the form. I
Okay.
thought, it's no brainer, I need to do this.
Okay. So one of the things about the form, that consent form, is that we always make sure that you're clear and you're happy. And that's not just at the point you sign it, but all the way through. If it's okay, can I talk a little bit about the chemotherapy and what we're trying to do? Would that be okay?
Yeah, sure, that's fine.
If you don't understand anything I say at any point, just stop me and we'll go back and we'll find another way. Is that okay?
That's okay.
Fine. So the aim of this treatment, this chemotherapy, is to reduce the chance of your cancer coming back. So with your surgery, the cancer was removed. We know that a small number of people have the cancer come back at some point. And we know you're looking worried. Are you okay?
Yeah, but I understood that the cancer was guaranteed to not come back again with the treatment.
Okay. The chances are that it won't come back. So if we looked at a group of people with your sort of cancer and we looked at them in 5 years' time, about 1 in 4 of them will have had the cancer come back. So about 25% will have had the cancer come back.
Right.
You're still looking worried, Angela.
I'm just not very good at numbers. So
Okay.
Sometimes when we talk about percentages, I get really confused. I was never good at it at school.
Okay. If I used words, would that help?
Yeah, try words rather than numbers.
Try words. Okay. So most people, when we look at with your sort of cancer, if we look at them in 5 years' time, their cancer hasn't come back. But about a quarter, it does come back.
Okay.
Is that a better way of describing for you?
Yeah, I can understand that. A quarter's quite a lot.
A quarter. That's what we think. And because it's a quarter, we want to try and reduce that. Okay. So what we do to that, what we offer to that group of people is chemotherapy. With the chemotherapy that you've had discussed with you, and we look at them and we offer them that chemotherapy, and we know if we give that group of people that chemotherapy, that quarter goes down to 1 in 10.
1 in 10.
Yeah. So it means then that, sorry, you don't like percentages. I was just about to say a percentage. You're still looking really worried.
Just 1 in 10 doesn't guarantee then that it's not going to come back.
No, I'm afraid it doesn't.
That's why I signed the form. That's what I understood.
As a guarantee. It's hard to hear that, isn't it?
Yeah.
So,
like, what's the point of taking the chemotherapy if it doesn't?
And some people think like that and they choose not to have chemotherapy, and that's okay if that's the right decision for you. As doctors, we know that overall we make things quite a bit better by taking it down from 1 in 4, from a quarter to 1 in 10. Okay, a tenth. So we make quite a bit of difference, is what we as doctors think.
Can I say that if it doesn't fully cure everybody, cure me at least, can we look into something else? I mean, I've got friends of mine, really good friends of mine, have been doing a bit of research on my behalf, and they've come up with loads of alternative stuff that we could try. And I'm kind of a bit tempted, a bit interested in some of them.
Okay.
I'd like to
go on.
Well, there's antioxidant sort of supplements, lots of different ones you could take. And there's even like cannabis that you could take. And they said that they're really good and effective for getting rid of cancer in the body.
Okay. And a lot of people ask us about that. And it's really good that you've obviously got supportive friends that are trying to look out for you. And that's really good.
You have 2 minutes remaining.
I think one of the things to think about is we know that the chemotherapy we've talked about, we've done lots of studies that show that it definitely makes a difference. It isn't a guarantee, but it makes a difference. What we don't know with things like antioxidants and cannabis is that it definitely makes a difference. Okay, so that's the difference between the chemotherapy and the antioxidants that you've talked about. Okay.
Right.
So what we say is we'd like you to have the chemotherapy for the reasons we explained. We prefer you not to just use the antioxidants and cannabis because we can't be sure that they will work because the evidence isn't there.
Does that mean I could do both then?
But some people choose to do both. So what we say is because some of the antioxidants and cannabis can work against the chemotherapy, we always say, ask us, tell us what you're taking so that we know and we can tell you whether we think it might be safe to take them together, because some people do. But I wouldn't want you to think that using the antioxidants and the cannabis on its own is going to reduce the chance of your cancer coming back. But the chemotherapy we know on average, overall, does do that. Okay, you're still looking a bit worried. Are you all right, Angela?
Yeah, I'm all right. I'm just thinking about how my life was just turned upside down since the original blood test and what I'm going through now. To hear that
it's now finished.
But it's important that you take time to make this decision. You don't have to make it today. I can make an appointment for you to come back in a few days once you've had a chance to think about it. Is that okay?
Yeah, that's okay. Today was my first treatment. I can actually miss that out and just take a bit more time.
If you need time, you take time.
Okay.
Okay.
Yeah.
Thank you for your time. Is there anything, we have to stop now, but is there anything?
No, you've explained a few things I didn't know, so thank you.
You're welcome. I better go. Unfortunately, I need to go somewhere else now, but see you soon.
All right. Thank you.
Bye-bye.
Bye.
Okay, your reading time is now finished and your 10 minutes is starting. Please begin the consultation.
Hello, my name's Jill Bishop. I'm one of the doctors on the unit. My nursing colleagues tell me you've got some questions about your treatment. Could I ask your name, please?
So, Angela Brown.
Okay, thank you. So could you tell me what sort of questions you've got?
Well, talking to the nurse earlier on, she was telling me that I had kind of unrealistic expectations with the treatment I'm about to do in the next few minutes or so. I was saying to her that I think this is going to guarantee that the cancer's not going to come back.
It does mean that the cancer's less likely to come back, and we'd quite like you to have this treatment because of that. And what I'd like to do is to talk to you about the differences it makes.
Okay. Yeah, that's fine. I've been through so much in the last few.
So what it does is, it's not a guarantee, but we know that there's a risk that your cancer come back. So you've had your surgery, your cancer's
Still recovering from that. Yeah.
okay. So your cancer's been removed. We know it can come back. So we give you chemotherapy to reduce the chance of that happening. And we know that your disease-free survival in 5 years improves from 75 to 90%.
Sorry, I don't understand what you mean. Can you say that? What did you say?
Which bit didn't you understand?
You said something about survival. I thought that I've survived. I've done the operation. I'm healing a bit. I'm a bit sore still. Are you saying something about 20% or something?
So if we have 100 people like you with your sort of cancer, and we look at them in 5 years' time without chemotherapy, 25% have their cancer come back, and with chemotherapy, about 10% have their cancer come back. So it reduces the chance of your cancer coming back.
What do you mean by people like me? Do you mean
people with your sort of cancer? People who've had your sort of gut cancer?
I'm not sure if it's I'm not sure if it's something I should go through. I signed the form because I thought it was going to guarantee that the cancer's not going to come back and that you're going to mop up any cancer cells that are left behind in my body. Now,
That's
the
right.
only sounds like quite a lot of people don't even need it then.
So we think that most people do need it, but you're right, not everybody's cancer comes back, and we're just trying to make that chance as big as we can, because we know that overall it improves your survival.
I don't know. It just sounds like I've been through so much already. I mean, have you got any idea how much I've been through in the last few weeks with all the tests and the biopsies and the hospital treatment? And
Sounds like you've been through a lot. Yeah, it sounds like you've been through a lot. I can see that you've been through a lot.
I think I'd like to try something else.
What would you like to try?
Well, I've been looking into some alternative natural stuff, one that actually would give me less side effects. I'm not too worried about the side effects. I just want to know that the thing that I'm going to take is going to work. So my friends have been looking at things and they've told me about stuff online we've seen on the internet, and there's like supplements you could take, like antioxidants that you can take. There's like cannabis that you can take. You can either smoke it or take it as a supplement you can take internally. I'd like to. What do you think? I'd like to try one of those.
Well, we haven't got any evidence, any proof that those treatments make a difference, but we've got proof that chemotherapy can make a difference. So I wouldn't advise you to have any of those treatments because we don't know that they'll work. But we know that chemotherapy.
But we don't know unless we try. I don't mean to be rude, but you don't know whether I actually need the chemotherapy or not.
I know that that patients like you usually have chemotherapy and overall benefit from chemotherapy.
I don't feel good about this.
Is there anything else that I can tell you that might help?
I just want to feel safe and feel cared for. I think I might have to just put it off for a bit, maybe come back. Could I like take some time out, 3 months, 6 months or something, and do this later?
Well, we'd prefer you not to do that. But if you need some time to come back and talk about it in the next 1 or 2 weeks, we can arrange that. And if you'd like to see your previous team, the team you first saw, to talk it through again. But we don't like to leave it too long because we know that chemotherapy may not work as well then.
Right.
What would you like to do?
I didn't really understand the numbers thing, whether it made it worthwhile or not.
Okay.
I think I don't want to go. I think I don't
Okay.
want to do it.
Well, the numbers thing, which bit of the numbers didn't you understand?
You have 2 minutes remaining.
I find it hard to repeat what you said because I didn't understand it in the first place. You said something about 3 years and 5 years. Isn't the chemotherapy meant to stop it coming back?
Okay, so on average, it does stop it coming back. If we looked at patients with your sort of cancer in 5 years' time, 75% would be okay. 25% would have had the cancer come back.
That's
without
quite high.
treatment. Yeah, without treatment. If we give you chemotherapy, about 90% don't have the cancer come back with chemotherapy, and about 10% do.
But the difference isn't big enough, I don't think. I think I'm going to leave it.
Okay, well, I'd really recommend that you thought about this in a little bit more. Perhaps come back and see one of my colleagues and talk it through again.
Can I take the supplements with the treatment? Can I do both?
We'd prefer you didn't, but some people do. We prefer you not to because we don't know they work and we worry that they can work against the chemotherapy that you have.
Your time is now finished.
I'm going to introduce myself. I'm Jill Bishop. I'm a consultant oncologist in Liverpool. And we have been doing some role playing of the comms station for the part 2B, and I'm going to let my colleague introduce herself.
Hi, I'm Louisa Eyo, and I'm an actress, do lots of role play, lots of theatre work. Yeah.
Okay, so what we're going to do now is we are very definitely out of role now and ourselves, and we wanted to just talk through both of the scenarios that we did, what we hope is an effective one and one that we hope was a less effective or demonstration of a less effective consultation, and to talk through not so much the mechanics but to talk through the effect that particularly Louisa as Angela Brown felt of each of those consultations. Okay, so I'm going to ask you, thank you for your help, was the first thing.
You're welcome.
And could you tell us a little bit about how you were feeling in the first consultation, which is what we hope is the effective consultation?
I think with the first one, I felt quite comfortable. I had lots of questions. I found that they got answered. I felt it was quite a compassionate kind of meeting. And I felt encouraged by the fact that I had choices, that things were being explained. There was very little jargon. And also I had a choice as to whether I do it now, whether I go through the chemotherapy now, whether I do it later, whether I mix it with some alternative stuff. There was no judgment there on that. It was quite easy to talk to you.
And is there anything in particular that I did that made you feel that way?
Partly,
this isn't to make me feel good. This is to illustrate the points.
Yeah. I noticed that sometimes when I'm thinking, I am playing the character thinking, there are expressions that are on my face. There's a bit of a frown, or I've got a question coming up, and you picked up on that. So you actively listen. You were really looking at my body language, and actually you would actually acknowledge it and say, you look a bit concerned. What are you thinking? Or tell me what you think, what's going on. And I really appreciate that. You did it about 3 times, and it made me know for sure that you were listening and that you had empathy in terms of what I was thinking as well. And that you were willing to stop, go with me on it, and then explain it even further. But you were doing it based on the cues that I was giving you, and that was all unconscious, but you were literally dealing with it. I love that so much, because that is empathy. And you were building rapport based on that empathy that you were showing.
Okay, so from a communications point of view, that's reading non-verbal cues, interpreting body language, empathy, and also checking back with the patient.
Absolutely.
What the problems are, but still finding other ways to explain things, but still keeping the conversation on track. Is that a fair summary? I would say
absolutely, yeah.
Okay.
Because there's no judgment, there's no real judgment there at all. You are actually very open. You can do this. I do recommend this. And you can take your time to think about it. You were very generous about that. You said, you can really take your time. If you want to, if you need more time, that's fine. And that made me feel it would be okay to go ahead with it. I may do it in 2 weeks' time, but I felt that I trusted you, so therefore I trusted the process.
Okay. And can I ask if because trust is a really important part of communications, and one of the reasons patients will or may decide to have a treatment or not does relate to their trust in a team or a clinician.
Yeah.
Can I ask how important you felt that trust, developing that trust was?
It's essential, because the character has been through so much already, and that was acknowledged. So I felt as if they kind of got to know me even before we had the meeting. You know, they knew about the biopsy, they knew about the journey that I'd been on a bit. So, and I know that the cancer therapy treatment is going to be something that was going to run for 3 months. So the trust has to be there, because it's not something you just dip in and out of or decide halfway through, oh, I'm not going to do this anymore, normally. So the trust was important. I knew that you were kind of on my side and quite supportive and genuine, being honest and recommending this as kind of the best treatment. And because it was coming from a friendliness, just being friendly and being honest, but being encouraging and quite positive. That's where the trust is built, really. That's what, yeah.
Okay. And this is the $64,000 question. So if you had really been that patient in my clinic, I should say I don't treat colorectal cancer. If you had been that patient in my clinic, what do you think your eventual decision would have been?
I think I would have probably gone away thinking about the meeting for probably about 2 weeks. I may, even if I was able to, probably either called in and had a phone call, another final conversation, or an email to then say yes to it, knowing that I could also try some other alternative therapies at the same time, if I wanted to. So I think I would have gone ahead with it and would have been quite positive about going for it, really.
Okay, and I think that's really important, because in a competent patient, you need to have the choice, but as doctors, clinicians, we need to be clear about the recommendations and why we're doing something, but still allow the patient has a choice and give them that space.
Yes.
Which is why communicating it is so important. So, but you think you would probably have had it, which is great.
Yeah.
Okay. All right. Shall we move to the next one then?
Okay.
So shall we move to the one that we found, well, that is designed to demonstrate a less effective consultation. And I'm going to say that I felt incredibly uncomfortable doing that consultation, because I was deliberately exhibiting behaviours that I would not normally exhibit, and I know it made me feel really uncomfortable. But most importantly, because you were the patient, how did it make you feel?
If I'm really, really honest, I can say that I'm still feeling the effects of that role play. It shows you just how powerful it is. We had a conversation for 10 minutes, and an hour later, I'm still feeling a little bit shaky inside. I think I would be honest to say that I felt stressed. It built up stress in me. Or even a kind of nervousness. I'm amazed at how it's affected kind of my nervous system.
Sorry.
And yeah, that's okay. And I think that's because of so many small things that happened. For example, at the very beginning, you didn't get to know me, or you didn't get to know the character. And she was then trying to bring in her story so she could talk a bit about that. Because I think when you get your story out, you can then park it and then listen. But because that didn't happen, we went straight into business, and the conversation was the flow wasn't so great. It was quite stilted, even a bit abrupt. It was quite serious. I know that you interrupted the character several times. That's like a real no-no, real no-no. It's the absolute opposite to listen. It means you have your own agenda and you want to get that out, and you're not picking up on small cues. Often when I said I didn't understand something, you say, well, what did you not understand? That's not helpful.
No.
Because it suggests that I'm the one with the problem. Rather than unpicking what you meant or what you said, it's like, well, what's the issue? So it's easy to feel stupid.
Okay. Can I ask, just for anybody watching this, what phrasing would have been useful in that setting? Because patients don't understand something. What we say is quite complicated sometimes, and it is really important we don't use jargon. We do explain it clearly, and we find a way. What phrasing would you have found helpful?
If you could have said something like, can you tell me more about that? Because it's an open question, and it allows me then to give you so much more information that isn't 1 or 2 words. But then I would have been able probably even to talk about what happened right at the beginning, you know, so that the conversation is more kind of equally kind of balanced, you know. So can you tell me more about that when I don't understand something? Or you saying, is it okay if I go over it again and I try and find another way of saying what I'm trying to say? I didn't feel judged so much. I just felt as if I was being told what to do. The character was being told what to do. I don't think that's a good idea for going for those other treatments, because there's not enough evidence. There was kind of strong opinions from you, and I would have loved it if you had actually asked me, what are my opinions? What do I know? Just to open up the conversation more.
Yeah.
And that didn't happen. No.
So what we ideally do is find out what the patient knows, ask them about themselves, ask them how they like things to be explained to them, find out with open questions, the how,
Yes.
what, why, where,
Yeah.
when questions, and then let them do the work, and we sort of summarize and clarify and find another way. And
Yeah.
so although you didn't feel judged, you did feel as if you were being talked down to. Did I understand correctly? Or not?
Yeah, there was a little bit of that, being talked down to, but being kind of told what to do. And
Right.
Yeah.
So very, very paternalistic.
Yeah, almost pedantic. This is how
Yeah.
we do it. This is what we want to do. And I thought, why? I was thinking, why is she speaking to me like she's a robot? There's something robotic about just delivering the information, saying, no, that's not useful. We need to do this. And not softening the edges a little bit.
Yeah.
You know.
Okay. Yeah. Okay. So that's also about active listening to the patient, listening to the body clues, the non-verbal clues, because you were clearly looking quite worried at times, and I deliberately wasn't picking up on it.
Yeah.
Okay,
Yeah.
so those sorts of things as well. The open questions, the checking back, finding another way.
Yeah.
Okay.
And also, if we find ourselves both speaking at the same time, one of us has to stop. Or let the person finish the sentence. You know, when there's two people speaking at once, it's not helpful.
Yeah, okay. And again, before I ask the $64,000 question, is there anything else you'd like to add that you think anyone watching would, and trying to learn from this, would find helpful, that you want to bring out that we haven't already discussed?
I think it's really important to have a really good beginning. So when we meet up and have that meeting, it's like, how are you? Never happened. How are you? But definitely in that beginning, literally find out how they are, find out what's been going on, and express a way to express being inside their shoes, you know, that empathy, which is basically just building a rapport, just building a conversation that flows both ways. And it's also to be silent, to be still as well, because sometimes the conversation was so kind of stilted that we could have actually stopped and paused. Because in the pauses, there's space to kind of think and feel where each one is. We didn't even do that. So I would say take on some of those.
So beginning is really important. So ask the open question at the beginning: how are things? How are you? How can I help? Yeah, those sorts of questions. Okay. So getting that understanding, that baseline before. Okay. And the $64,000 question. If you had come into my clinic, if you had been that patient, what do you think your decision would have been about chemotherapy?
if I'm really honest, I definitely would go home and park it for about a month.
Okay.
If I
Yeah,
could
yeah.
get away with that, put it off, put it off, put it off. Probably not come back, even though I've got this situation. Either it means that I'll go for, I don't know, a second opinion, speak to somebody else. But I didn't feel at the end of that happy at all. In fact, because I'm recovering from an operation, the character is recovering from an operation, she's still sore in some places. She's walking a little bit. She's thin and she can just about go back to work. I think I could probably move into kind of a low mood.
Yeah.
And not want to have the chemotherapy at all.
Okay. Which then, from a medical point of view, potentially compromises your survival, and there's no guarantee it would.
Yeah,
that was the point of the conversation. But it might mean that a patient who has a reasonable chance of benefiting from a treatment chooses not to have that purely because we did not communicate the information in a way that was accessible to the patient.
Yeah.
Okay.
Yeah.
Okay. Which is what we wanted to illustrate from showing these two consultations and the effect that it can have on a patient's decision making and a family's decision making for the future. And I think it's really important we remember, and that the conversation is very much about how the effect it can have on our patients if we don't get it right. So yeah. So thank you very much. I enjoyed the first one. I can't say enjoyed the second one, but thank you very much for your time and for talking this through. And hopefully it will be useful to my future colleagues, and God forbid your future interactions with medicine. Okay, but thank you for your time. That's great. All right.
You're welcome. Bye.
Bye-bye. Bye.